Good afternoon, everyone. Thank you so much for joining us for this month's Teach Educational Rounds. Here with us today, we have Kevin Haynes and Jama Yusuf, who will be presenting on optimizing cessation outcomes in Black communities throughout the Greater Toronto Area. We're going to begin today with our land acknowledgement. CAMH is situated on lands that have been occupied by First Nations for millennia. Lands rich in civilizations with knowledge of medicine, architecture, technology, and extensive trade routes throughout the Americas. In 1860, the site of CAMH appeared in the Colonial Records Office of the British Crown as the council grounds of the Mississaugas of the New Credit, as they were known at the time. Today, Toronto is covered by Toronto Purchase Treaty 13 of 1805 with the Mississaugas of the Credit. Toronto is now home to a vast diversity of First Nations, Inuit, and Métis who enrich this city. CAMH is committed to reconciliation. We will honor the land through programs and places that reflect and respect its heritage. We will embrace the healing traditions of the ancestors and weave them into our caring practices. We will create new relationships and partnerships with First Nations, Inuit, and Métis, and share the land and protect it for future generations. So now I invite everyone to introduce themselves in the chat and let us know which traditional territories you are joining us from today. And if you are unsure, you can visit this website. I'll put it in the chat in a moment and you can find out. You're also welcome to let us know something you are doing to learn or improve your commitment to reconciliation. And in the meantime, while everyone's sharing, I'll share my own personal land acknowledgement. My name is Rachel. I am a second-generation Canadian currently located on the lands of the Mississaugas of the Credit, which is covered by Toronto Purchase Treaty 13. I am committed to reconciliation, and I continue to listen and learn about the stories and cultures of various Indigenous communities and ensure that their voices are heard. So I'm just going to keep on going with some housekeeping announcements, but everyone please feel free to continue sharing in the chat. And if you are interested in receiving a letter of completion for this Teach Educational Rounds, please make sure you have registered for this webinar and completed the pre-learning assessment. As well, make sure you have signed into this webinar using your full first name and last name so we can track your participation. And finally, make sure to complete the evaluation and post-learning assessment, which will be emailed to you by the end of tomorrow, and you will have 1 week to complete that. And also note that a copy of today's slides along with the recording will be sent by tomorrow as well. So here's a little more information on our presenters. Kevin Haynes is the Senior Manager for Black Health Strategy with the Provincial System Support Program, PSSP, at CAMH. And Jama Yusuf is a Research Coordinator at CAMH in Intrepid Lab, where he primarily works on the HCCF project. And here are their disclosures. And just to note that the content of Teach Educational Rounds are centered on evidence-based guidelines from the following sources. And nonetheless, these materials, as well as the verbal presentation and any discussion, represent only general principles, and they do not remove the need for clinical assessments or treatment plans by healthcare professionals. And please feel free to use the chat feature throughout the webinar to post any comments or answer any prompts by the presenters. And so to do this, you can click on the speech bubble icon in the control panel, and please make sure you just select everyone so that all panelists and attendees can read and respond to your comments. And then just to let everyone know, all content related questions will be answered at the end of the presentation. So please keep note of anything that comes up, and then you can post them in the chat during our Q&A period, and Kevin and Jama will answer them. And with that, I will leave it for Jama and Kevin to take it away with their presentation.
Awesome. Thank you so much, Rachel, and hello, everyone. Thank you all for joining us today for our talk. Happy last weekish of Black History Month. It's a leap year, so we got an extra day. So it's a good win. But yeah, we will be getting into our presentation today and really talking about our project focused around developing smoking cessation, smoking cessation supports for Black communities across the GTA. So by the end of this webinar, we're hoping that we will be able to discuss the importance of partnering with and supporting Black-led, Black-serving organizations, be able to describe some of the themes that emerged from focus groups and interviews that were centered around smoking cessation across diverse Black communities, as well as examining the challenges faced in a smoking cessation project tailored towards Black communities and applying those insights to really enhance culturally responsive interventions. So to really kick us off, I'm going to pass it off to Kevin, who will be going into our first bit of content.
Thank you, Jama, and thank you everyone for joining us. As Jama said, happy Black History Month to all folks on the call. It's really exciting to share some of the work that we're doing and through this partnership with our team and the wonderful folks at the Intrepid Lab. So we really appreciate the support that we've had in terms of moving some of these pieces of work forward and really understanding that this is work that really hasn't been done in the system. There's such great need when we look at Black communities and health disparities. So it's really important to highlight projects like this as an example of ways we can partner with marginalized communities to improve health outcomes for everyone. So on that note, I just want to kind of start with somewhat of a primer just to kind of set the stage in terms of current state with Black communities and health outcomes in Canada. So as many of the folks on the call may know, Black Canadians experience disparities in health outcomes when compared to the overall population. And this is due to a multitude of factors, right? And we're going to get into some of those as we progress through this presentation. But we can look at systemic impacts of racism, which we'll talk about a little bit. We can look at, distrust in the healthcare system in general, which is sometimes often related to previous negative experiences or distrust in the system in general. Lack of access to services and information, and accurate health information that really helps inform communities to make informed choices, right? So when we put these multitude of factors together, we often see disproportionate health outcomes where we're seeing like higher, mortality rates in Black communities, less access to services, less Black communities being connected to primary care providers, and all of these things, less access to mental health care. And we know all of these things improve health outcomes, right? So it's really important projects like this really digging into the causality of some of these pieces and better understanding how do we target that to make a great impact. When we look at prolonged exposure to trauma, so sometimes when we talk about trauma as clinicians, many of us are guilty of just looking at trauma from, from a sensational aspect, but I think sometimes we don't think about race and how race impacts trauma. So I think sometimes a term that we often talk about when we're talking about Black communities and other racialized communities is race-based trauma or racial trauma sometimes, or race-based traumatic stress is another way that we might conceptualize that. And that's really understanding how race and the social construction of race impacts our experiences of trauma. So how we navigate the world, how others view us, some of the comments and our microaggressions that we might navigate through in various different systems, and what's the impact of that on our mental health, but also what's the impact on that on how others perceive us and how others might interact with us in the healthcare system, right? And sometimes those lasting effects can create these traumatic experiences, right? Where it make us say, you know what, like I had very negative experiences in this space. This is maybe not a space that I'm comfortable going back to. But as we know, that has significant health implications over time. So we look at Black Canadians, residents particularly, greater health disparities compared to other ethno-racial and ethno-cultural groups in Canada for many of those reasons. And then when we look at some of these chronic diseases that are often linked to kind of lifestyle, so like diabetes and hypertension and obesity, and of course genetic factors as well too. But when we look at some of these pieces in terms of how our lifestyle might exacerbate some of these expressions of these diseases, understanding that some of these traumatic experiences and stress that we're experiencing really has direct impact in terms of how we're able to take care of ourselves, right? And if we're not feeling at our best self, then we're not able to necessarily provide ourselves the best care, which is really going to create this kind of vicious cycle where we have, various different health concerns that we're trying to manage, and really not in the best mental or physical space to manage that. And get the next slide, please, Jama. So we talked about anti-Black racism. It was really a term coined by Dr. Akula Benjamin. Hopefully everyone knows of Dr. Benjamin by now, 2024. I hope folks have been doing their homework over the last decade, which has been extended, by the way. So if folks don't know, the International Decade for Persons of African Descent it has been extended for, I believe, an additional 2 years in Canada and North America. So that's a very exciting piece for us here. But anti-Black racism is very prevalent in many different institutions, and it's expressed in different ways, right? So I think sometimes people think of anti-Black racism as like overt expressions of racism, people calling you a racial slur, people, reacting to you in different ways. And of course, that is one experience of racism. But when we look at systemic racism, sometimes that manifests in a very different way. So we look at organizations, for example, and we look at entry-level positions, we might see, less prevalence of black representation in some of those entry-level positions. But as you kind of raise through the organizational hierarchy, you see that representation sometimes becoming leaner and leaner. So that's an example of an expression of anti-Black racism, right? If we look at, some of the larger macro level stats, if you look at, the forensic mental health system, we look at the criminal justice system in general and overrepresentation of Black communities in some of these spaces, underrepresentation in educational spaces. Sometimes a phrase that I kind of helps me to remember kind of these various different pathways is I often consider Black communities were often overrepresented in spaces where you wouldn't want to be and underrepresented in spaces where you would want to be. So if you let that sink in for a bit, think of many spaces where you would really want to see yourself represented, like educational system and employment. Those are often the spaces where we're seeing underrepresentation. And if we're thinking of spaces like the child welfare system, the criminal justice system, where you might not necessarily want to see yourself represented, those are often the spaces when we look at the stats where Black communities are overrepresented. So just really taking a minute to unpack some of those. I think those sometimes are often linked to expressions of anti-Black racism. And understanding that anti-Black racism is a determinant of health, and it negatively impacts our health for many reasons that we just talked about, including increasing or decreasing our ability sometimes to cope with some of these stressors that we're facing in our lives. Next slide, please, Jama. So what do we do about that? I think a term that we often talk about is culturally responsive care. And culturally responsive care really recognizes that a one-size-fits-all approach to healthcare delivery is not actually an equitable service delivery model, right? So when we think of equity as, really understanding that different folks have different needs, then I think just by definition, a one-size-fits-all approach is not sufficient, right? So we look at culturally responsive care, it's really understanding that different groups have different needs, and sometimes our needs are informed by culture and some of the social cultural differences between groups. So when we talk about Black communities, it's really understanding that Black communities are not a homogeneous group. There are many different and diverse Black communities. There's many different intersecting identities. So it's really taking a moment to understand how does culture impact how our understanding of health, our understanding of ourselves, our understanding of the healthcare system and what an intervention means, our understanding of the world around us, and really being purposeful in including and embedding principles of that in our intervention. So what can that look like? In many spaces, that can look like increasing representation in care, right? So understanding that, none of us can be the expert in everybody's experiences. The best way to bring those diversity of perspectives is to have a diverse employment or a diverse workforce, right? So that different expressions of culture and different understandings of the world around us are embedded in our team, right? I always say it's not something that we can train ourselves out of, right? There's no one training that's going to make us all culturally competent and be able to serve everyone, right? It's really diversity, a diversity approach. Of course, training can help to build bridges, but we have to be purposeful in all aspects in terms of how we're looking to intervene, not just from the micro level, but we think of from a systemic level as well. One of the words that I really love in this phrase is the responsive piece. And I think of responsive being a verb or an action word, right? It's different than, what we might talk about just by saying culturally competent, right? When I think of responsive, it's a reminder that we need to do the work. We need to take action. It's not enough to just have a training and say, I'm done. It's how do I continue to look at the client in front of me? So this idea of client-centered care and family-centered care. How do I continue to understand that culture is important in this client's life, the same way it's important in my life? And how is culture and race and all these different pieces, how is that impacting their clinical presentation? And how am I going to bring that knowledge with me into the intervention, right? So that this intervention that I'm doing with this client or this family is going to look maybe completely different with my next appointment, understanding that culture is very fluid for different persons. Thanks, Jama. Next slide. So an example of partnering with diverse communities. So often in Black communities, we sometimes hear of what we call B3 organizations. So these are organizations that are Black-led, Black-serving, and Black-focused. So that's where the B3 comes from. There's a lot of great organizations doing great, tremendous work. I don't even want to begin to name some of a few, but if I think of our partners with our SAPC program, the Substance Abuse Program for African, Canadian, and Caribbean Youth, so many of these B3 organizations, through the network. If I think of organizations like CAFCAN Services, Taibu Community Health Center, Roots Community Services, just to name a few, that are really Black-led organizations that are really trying to take a deep dive into this idea of culturally responsive care. Understanding it with Black communities as well, that often includes incorporating Afrocentric principles to care, right? Understanding that our clients are people of African descent, and how do we bring some of that cultural knowledge into how we understand the world and our interventions. So this collaboration is key because, again, in mainstream organizations, we can't do this work on our own, and nor should that be our plan, right? It's really about partnering, and sometimes when we think of partnering, it's how do we partner and also lead from behind, right? We don't have to be at the forefront for a partnership to kind of get our accolades. It's about how do we do these things for the right reasons? How do we support community and build community resources so that we're not just kind of flying in to do a study, we're building the community's capacity to take care of themselves so that when we leave and after all this studies and all these focus groups are done, the community has something that they can point to say, this is how we benefited, or this is how we're going to continue to grow from this amazing work. So if we flip to the next slide, understanding that these are some of the important pieces, I really want to highlight this this study here. If folks haven't read this paper, I had Jama put that nice reference there. Thank you so much on the slide. If folks haven't read it, I really encourage you to please take a moment and write this down or take a screenshot, and you can crop out my picture from your screenshot when you do. But take a screenshot and really write this down. This is a great study from our colleagues at the Black Health Alliance that really looked at like a social network analysis, looking at Black-led or B3 organizations and inter-organizational partnerships with the mainstream sector. So just taking a moment to look at this visual, I think one thing that really sticks out to me is that I don't see any lines between the Black-led organizations and mainstream organizations. And I think this is really highlighting what we're talking about here, these idea of silos in care, where many Black communities are accessing services in places that are comfortable for them. But mainstream organizations aren't really partnering with these Black-led and Black-serving and Black-focused organizations in purposeful ways, right? And that in itself is impacting health outcomes for Black communities. So, we talk about meeting folks where they're at. We can see where they're at. We can see the dots on this map, right? So I guess the question we need to ask ourselves is, why aren't we meeting folks where they're at? And I think when we look at a visual like this, it's both inspiring to think of how much opportunity there is in front of us, but it also is thought-provoking in terms of how do we reorganize our system so that there is greater lines both between these B3 organizations, but also connecting to mainstream organizations, right? So when we think of that in its entirety, that's what we mean when we're talking about dismantling anti-Black racism. So if we flip to our next slide, I have a question for the group. We're going to do things a little differently. I heard this is a teach first, so hopefully folks will indulge us in this. Just asking a question for folks to reflect on, and please feel free to either drop this into the chat or unmute yourself if you're able to. So within your role in your organization, what are some steps that you can take to support better collaboration with B3 organizations? Please feel free to drop some comments in the chat, or if anyone is feeling courageous, please feel free to take a moment to unmute yourself and think of what's one way that you can maybe make an impact in terms of better supporting collaboration.
Yeah, and if anyone wants to unmute themselves, just put it in the chat and I can unmute for you.
we'll take 1 minute to reflect, and we'll ask our colleagues to check the chat if there's any things trickling in. What are some ways that you can better support these collaborations? I might ask you, Jama, if you're able to see them.
Can you hear me? Yeah, so Aya's actually responded and said identifying organizations within their region that are Black-led and seeing if they have any common initiatives.
That's great. You know, everything we can do is a great start, right? So really identifying some of those Black-led organizations. If there's any common initiatives is a great start. We can also think to, are there initiatives, even if not in common, that are aligned with our, you know, with our mandate or our values, and how do we also support maybe to get involved in some of those initiatives as well. So that's a great example. Okay. In the interest of time, please feel free to continue to put your thoughts in the chat, but I will pass to my colleague Jama. And I also want to take a moment to acknowledge Jama and the great work that he's been doing in supporting and leading this project as well. So really excited to share some of the updates and where we're at in terms of really digging deep and meeting with community to further this work. So over to you, Jama.
For sure, I appreciate you, Kevin. And honestly, it wouldn't be like as nearly as successful if it wasn't for, you know, organizations like Cessation, like CAFCAN, like BHA, like being there and being involved is really what's most important, having people present. So we talk about having, you know, things that are tailored towards our communities, but we need individuals from our community to take that step forward. So I appreciate you as well for being as heavily involved as you've been. But yes, I will be talking to us about the project. So our project is called the Equitable Health Project, Improving Cessation Outcomes Within Black Communities. So really, what is the problem that we face and what is the problem that we're trying to address? So Black adults, when you look at this from afar, you see that Black adults have a smoking prevalence that is half that of white adults. Sounds good. They also smoke fewer cigarettes than Black adults as well. Sounds great. But yet they are more likely to die from smoking-related diseases than white individuals. Not so great. So tobacco companies in the past have also disproportionately targeted Black communities in their marketing and in their promotion of tobacco products. And we've seen this throughout history, but particularly with the targeting of menthol products. And it's also important to really take into consideration that programs that are designed for marginalized communities, BIPOC communities, are often not grounded in their voices, right? We see that organizations tend to develop programming for communities and not alongside communities, and not really having those elements of community consultation and involvement. And as a result, it results in their voices, their involvement being passively viewed in health disparity programming and in research. So it's really important for us to really examine the needs of Black individuals who use tobacco to really assess the ways in which programming and services can be culturally responsive, culturally informed, to really suit the needs of community members. So what is this project that we are trying to do? So really this project, the aim of it is to design a culturally responsive and relevant smoking cessation program that is specifically tailored towards the needs of diverse Black community members in the Greater Toronto area. So the reason why we use that specific term, diverse Black communities, is because within our Black communities, and as Kevin mentioned earlier, it is not a homogenous group. There's so much heterogeneity that exists within Black communities. There's so many diverse subgroups of Black communities that exist. And what we wanted to do through this project was to really ensure that we are accessing those, we are tapping into those communities, and we're really getting a lot of feedback from diverse perspectives. And we do this by implementing a community-based participatory research approach, which we'll talk about in a bit more detail later on. Again, this is a 2-year project that was funded by the Public Health Agency of Canada under the Healthy Canadians and Communities Fund. And the aim of the fund was to really improve health by supporting interventions that prevent chronic diseases, and addresses one of 3 risk factors. So physical inactivity, unhealthy eating, and tobacco use. And I'm sure you know which stream we ended up choosing. So the project is designed in collaboration with CAMH and with Black Health Alliance, but we also have different other partnering agencies as well. And as Kevin mentioned, some of the amazing work that different Black-led, Black-serving, Black-focused organizations there are in our community, such as Taibu and CAFCAN. Those were some of our partnering agencies as well. To just give you a bit more of an insight as to what each organization does. Black Health Alliance really focuses on improving the health and well-being of Black communities across Canada through health promotion and engagement, research and policy, and strategy design and implementation. We have CAFCAN Social Services that really focuses on African Caribbean youth and their families and ensuring that they have access to social services in a culturally affirming environment. And also Taibu Community Health Center, which offers Black identifying clients in the GTA access to primary care, health promotion, and disease prevention, again, in a culturally affirming environment. So really great work that they're doing across all their organizations, and I highly recommend if this is something that if you're interested as a mainstream organization in partnering with different Black-led organizations, those are definitely a few to check out and to reach out to. So here I wanted to show you a map of the GTA. We're broken down into all 25 different wards. And you see that we've highlighted Ward 1, which is Humber River, it's Etobicoke North. Number 7, which is Humber River, Black Creek, and 23, which is Scarborough North. And the reason why we're highlighting these 3 is that these are the communities with the highest proportion of Black individuals living in them in Toronto. So we really focused our efforts in these 3 regions to really ensure that we're tapping into the diverse Black communities in the GTA and ensuring that, if there's a higher number of Black individuals living in them, there's a higher likelihood that we'll be reaching out to individuals who would be most in need of services, such as smoking cessation services. So I mentioned community-based participatory research, and this approach really recognizes the importance of involving community members as active and equal participants in all aspects of the project, in all project phases. So this is done to ensure that the community priorities are addressed and that their health and well-being is really at the core of the project. So why is this really important? So by really applying the main tenets of CPBR into our project, we consider the lived experiences of our participants in regards to anti-Black racism, culture, language, and intersecting identities, and also empowering them to share their thoughts and feedback to really generate the desired knowledge that we're looking for. And we've done that, and we also do it to ensure that the community's health, the community's priorities, their needs are addressed and is at the forefront of our project. So one of the things we've done to try to stay true to those tenets of CPBR is developing an advisory group, which Kevin so thankfully sits on. It consists of researchers, clinicians, scientists, subject matter experts, and people with lived experiences, all of whom who have supported and will continue to support all decision-making processes related to the project. So what are some of the main activities that we've done as a result of the project? So we conducted a literature review and an environmental scan, really to better understand the evidence that exists to support smoking cessation for Black communities across Canada and different subgroups of Black communities. We've conducted focus groups and interviews to really elicit the experiences of community members to share their experiences using tobacco and what they think should be included in a culturally relevant, responsive, and acceptable smoking cessation intervention for Black communities in the GTA. And we've also conducted an evaluation of the project through interviews and a survey to really evaluate the extent to which the results of the focus groups and interviews, as well as our suggested next steps, are relevant, acceptable, and feasible for diverse Black communities across the GTA. So here, I didn't want to focus too much time on this, but just to give you a timeline, a bit of a visualization of the timeline that we have gone through. We started off with our literature review and environmental scan back in 2022. We did our recruitment, which was a challenge in of itself, and it's something that we're going to talk about later on in our presentation. But we concluded that about early or late winter of 2023. Or early winter 2023, we did our focus groups, our individual interviews, which concluded in the spring and summer of 2023. And we just recently concluded our evaluation interviews, which concluded in the fall / winter of the past year. The literature review and environmental scan. So what did we do? So for the environmental scan, our purpose was really to identify any kind of services, programs, resources, anything that was developed alongside or developed tailored towards Black communities across Canada. And it was done in 2 different stages. So the first stage, we had a Google search that was conducted, and as well as targeting community agencies that operate the STOP program, which is a smoke cessation program offered by Intrepid Labs at CAMH within those 3 regions that I talked about. So Scarborough North, Etobicoke North, and Humber River Black Creek. And this was done just in the context of Toronto and Ontario. And in the second stage of our environmental scan, we focused across Canada to really see what really exists for Black communities in regards to smoking cessation. The results will shock you, but not really. There wasn't much. We didn't find anything related to smoking cessation programming or initiatives specifically for Black communities across Canada. And we also, through our environmental scan, really did not find any organizations that currently implement smoking cessation interventions, treatments, specifically towards Black communities in the GTA or across Ontario or across Canada. The literature review, our purpose of the literature review is really to find out any evidence that exists to support smoking cessation for Black individuals and subgroups of Black communities across Canada. And we also wanted to see what gaps exist in the evidence on effective smoking cessation intervention. So again, this was done in two different stages, with the first stage focusing on Canadian literature and the second stage focusing on UK and US literature. And these were some of the studies, the criteria of the studies that were included. Some of the results that we found were that pharmacotherapies were found to really increase abstinent rates, mostly in the short term. Sustained release bupropion was most effective in helping Black individuals quit smoking. We found that church-based interventions were effective, but really only in the short term. We found that in-person approaches were actually not as effective as direct and tailored approaches. We found that Black individuals who smoked were less likely to receive any quitting advice from their healthcare providers compared to white individuals. And this didn't really create a sense of mistrust between their healthcare providers and them, but participants felt, or Black individuals felt, a sense of frustration or a lack of care from their healthcare providers over inadequate smoking cessation counseling that they've received. So what are some of the recommendations that we found from the literature? So really what we found was that it's important to combine different quitting strategies. It's important to target early stages of smoking cessation. It's important to improve healthcare practice among healthcare professionals, increasing the number of cost-effective interventions, lowering the cost of medications, ensuring that community-based interventions are responsive to the needs of the individuals and the communities that you are working alongside, as well as, and the only way to really do that is to ensure that you're building meaningful relationships with communities and partnering with Black communities and B3 organizations, as Kevin had mentioned, and considering the needs of different subgroups and socioeconomic disadvantages that are faced by Black individuals. So here we share just a screenshot of we use the literature review information and environmental scan information to develop an infographic that was shared with focus group participants. And the idea of sharing this with them was just so that they had an understanding of what the literature says. We wanted to develop something that was very digestible, very easy to read, and also included some information regarding any kind of supports that they can access in the meantime as we're developing the smoking cessation intervention specifically for Black communities. So now we get into the bulk of our activities, which was the focus groups and the individual interviews. So the eligibility criteria here was pretty straightforward in some regard. Had to self-identify as Black, very, very straightforward in that regard. 18 years or older, sufficiently communicate and speak English. In regards to their smoking usage, we were looking for individuals who smoke tobacco products. So these included cigarettes, cigars, or grabba. So for those who are not familiar with the term grabba, grabba is a tobacco leaf that's commonly mixed with cannabis, to be in the process of quitting or have quit smoking in the past, and currently access services within the GTA. And for individual interview participants, we really wanted them we wanted to ensure that they were individuals who had participated in a focus group, so that the interview questions were kind of in line with what they were, it was a natural progression into those interviews. So for the focus groups, we hosted 4 focus groups in total with 18 participants, and we invited participants to share their experiences with using tobacco, how anti-Black racism and these experiences have really impacted their tobacco use, and really understanding their experiences with quitting or not quitting. We wanted, as much as we wanted, again, a diverse array of individuals from within the Black community, we wanted a diverse array of individuals in regards to their smoking cessation journey, among those who choose to quit, those who decided that they didn't want to quit, but really wanting to understand what were those reasons why, what was the motivations behind not wanting to quit, and so on and so forth. And we also wanted them to share what they considered, what they think should be considered when developing a culturally responsive, culturally relevant, acceptable smoking cessation intervention for Black communities in the GTA. So we really wanted to answer these two questions through our focus groups. What are the experiences of Black individuals in the Greater Toronto Area with smoking and or quitting smoking, and how does their racial, cultural identity and experiences of anti-Black racism impact their smoking? Additionally, we wanted to know what are the needs, preferences, and priorities of Black individuals for smoke cessation services in the GTA. Moving forward, we had done individual interviews, and the focus group, we invited focus group participants to really take part in those interviews. We had conducted 5 interviews, and really the interviews invited focus group participants and gave them the opportunity to unpack the complex relationship between systemic issues such as stigma, healthcare bias, racism, access to healthcare services, as well as individual experiences. So we're thinking about tobacco use and quitting in a very one-on-one safe setting for them. So next we're going to go into our data analysis phase. So from here, what we had done was we compiled our focus group and interview data. They were recorded, they were transcribed, and we used those transcriptions, and using those transcriptions through Deduce, we had done 3 stages of coding. So in the first stage, we had done open coding to really break down the data into loose codes. In our second stage, we refined those codes and organized them into a code book, and then we used that code book to conduct reflexive thematic analysis to find themes across the transcripts. And again, staying true to those tenets of CPPR, we shared the codebook with focus group and interview participants in a data checking survey to really ensure the accuracy, credibility, and validity of the findings. And again, just ensuring that at every step of the way, participants are aware of what we're developing, of what we found, and to ensure that those are in line with their experiences and what they've discussed in those focus groups and interviews. We had then found, so these were the themes that were generated from the focus groups and from the interviews. So the first theme that we had found was tailored smoking cessation strategies for Black communities. And within this theme, participants really expressed a need for tailored smoking cessation interventions that were uniquely designed for Black communities. And they recognized the importance of considering their specific needs and their preferences. One of the key findings is that the impact of anti-Black racism in healthcare, and emphasizing the need for systemic biases, emphasizing the need to address systemic biases and challenges within healthcare systems to support smoking cessation efforts. And it was also important to consider the factors that influence Black individuals' decisions to quit smoking, contributing to the creation of more culturally responsive smoking cessation programs. The second theme that we had generated was characterizing smoking in the Black community. So it was really important to understand the patterns and persistence of tobacco use amongst Black individuals, as this encompasses various aspects of smoking behavior, such as initiation, frequency, and narratives about their continuation of smoking. This understanding also offered valuable insights for tailored interventions to address the specific challenges faced within diverse Black communities. Additionally, the interactions between tobacco and mental health highlighted the complex relationships between the two, which emphasized the need for a more integrated approach that considered mental health factors in smoking cessation interventions. The concept of role identity really emerged as a key finding as well, and it emphasized the importance of considering how individuals within Black communities perceive themselves in terms of their smoking behaviors. So thinking about them identifying themselves as either a smoker or a quote-unquote non-smoker. And finally, we had our third theme that emerged, which was you and your community, locating oneself within their Black communities. So it was really understanding social factors and influences within Black communities to ensure that we're tailoring interventions that resonate well with community members. It also emphasized the importance of community and connection, which suggests that interventions should foster a sense of belonging and cultural relevance as well. And we also touch upon the role of accountability and support for participants, indicating that effective smoke cessation interventions for diverse Black communities should really prioritize mutual accountability and help develop support networks for participants. So here we share a draft plan for a smoking cessation intervention, smoking cessation program. And we created this and we called it a menu of services. Based on what our participants shared with us, they wanted something that was really flexible, adaptable, and wasn't really a one-size-fit-all approach. As a result, we created this menu of services. And when we say a menu, I want you to situate yourself in a pizza shop. You're either making your pizza from scratch, you choose your crust, you choose your base, you choose your cheese, or you're looking at a pizza that's already on the menu. say, meat lovers, but you don't want pepperoni, so you remove the pepperoni. In that regard, we wanted to create services that organizations can kind of choose and tailor based on their unique needs of the communities that they're serving, but also based on the capacity that they have as an organization. We also really wanted to put sustainability at the forefront. While if we were able to progress into the next stage of this program, into the next phase of funding, it would only be funded for about 4 years. We're trying to think about how long can we ensure that this program stays moving, stays sustainable, is working outside of that 4-year funding period, and that organizations are able to develop something that is self-sustaining within their organization. So as a result, we developed 4 different program offerings that I won't get into too much detail in right now, but going from less resource intensive to more resource intensive. So for example, behavioral support would focus primarily on behavioral support, and that might be just as much that the organization can offer, versus all the way here at the more resource intensive option, organizations can provide integrated cessation support. So this would include behavioral support, this would include peer support, this would include pharmacotherapy support, up to maybe 26 weeks of pharmacotherapy support. So it really is dependent on the organization, it is dependent on their capacity, and again, dependent on what the needs of their communities are. So now we go into our last bit, which was the project evaluation. And we use a developmental evaluation approach to really evaluate the extent to which the next steps and the results of the program and the results of the focus groups and interviews were acceptable rather than infeasible. And we also really wanted to explore the thoughts and perceptions of community members around their experiences in participating in both focus groups and interviews. And we utilized a survey and an individual interview to evaluate acceptability, appropriateness, and feasibility. So these were the questions that we wanted to ask. So in terms of acceptability, we wanted to know, are the results from the focus groups and individual interviews agreeable to the stakeholders being the participants? In appropriateness, we wanted to know, what is the perceived fit or compatibility of the results from the focus groups and individual interviews with the practice setting where a tailored smoke cessation program would be implemented. And for feasibility, we really wanted to know, can the recommendations from this project, can those suggested next steps, can they be carried out in a way that is carried out as intended with the existing means, resources, and circumstances? So similar to our focus group and individual interviews, they were recorded and they were transcribed as well. And we use those transcripts to conduct open coding based on acceptability, appropriateness, and feasibility. So we categorize those codes as either positive or negative based on the feedback that they had provided. And the survey data was also analyzed to gauge participants' agreement with the acceptability, appropriateness, and feasibility of the project results and suggested next steps. So the results that we had found were that survey data indicated that participants highly endorsed the acceptability, appropriateness, and feasibility / relevance of the program results, which includes themes and the draft plan for a smoke cessation program. And we also found 4 key takeaways that I wanted to share with you all. So building trusting relationships, and this again ties back into developing those relationships with community members, but not just developing those relationships with community members, but as organizations and mainstream organizations, developing those relationships and those meaningful trusting relationships with B3 organizations. The participants really discussed the importance of building a program with organizations that they trusted, and this stems from the long-standing mistrust between healthcare and Black healthcare communities, healthcare research, and Black communities. To really create an intervention that cultivates trust, we intend to collaborate with B3 organizations so that they can champion the intervention, and to ensure moving forward that we place a greater emphasis on establishing trusting relationships with community members before, during, and after project initiatives. Participants also talked about a very crucial need for peer support. They really spoke heavily about including peer support in the programming, and when we shared that this was something that we're including in our draft plan, they were very happy to see it. So it's really important for Black communities as it fosters a sense of understanding, shared experiences, and solidarity, while also addressing challenges unique to various subgroups of Black communities. So including peer support into smoke cessation services specifically for Black communities is essential, as again, it provides culturally responsive, relevant care, empathetic connections that address community-specific challenges, and fostering a supportive environment crucial for successful smoking cessation. Participants also talked about continuous programming. And again, similar to what we talked about in regards to sustainability, that is the intent behind developing the project or developing that draft plan in the way that it was. We want to ensure that the services that organizations are providing are sustainable, continuous, and that it doesn't really leave once the funding for the project is over. That is our overall goal in terms of developing a smoke cessation program to ensure something that is relevant to the community members and that is sustainable and there to stay. Finally, they talked about what we found was that they found adaptable and flexible programming to be very important, and we developed that in a way to ensure that organizations are developing a plan that works for them, a service, a program that really works for them based on their community needs, based on their organizational capacity, and something that ensures the sustainability of the program in the long term. So learnings and next steps. So what did we learn? What were some of the challenges that we faced? And one of the biggest challenges we faced was engaging community members. And this is something that we see when we, in the research community, in healthcare, engage with Black and Indigenous community members, considering the historical mistrust that exists between healthcare and research with these specific communities. And I think we initially, when we developed our recruitment strategies, we kind of approached it in a traditional research kind of way, sharing research, sharing the project flyers with community agencies and organizations, emailing healthcare providers just through word of mouth and social media. But we realized that this really wasn't the way to go, and that this wasn't really the way to resonate with community members in a way that was effective, and that would build trust with them. So we had decided to tailor it based on staying true to what we want to do in our project. If we're trying to tailor smoke cessation interventions to the needs of Black community members, we should also tailor the recruitment strategy to the needs of the community members as well. So we had done that by bringing the project to the community rather than asking community members to come to us, by having individuals within the community, by going to events and community organizations. We're providing them with a physical manifestation of the project, someone who's there to answer any questions that they might have and to ease any of the concerns that they might have in regards to participating with the project. And this, although the recruitment overall was a bit challenging throughout the duration of the project, this change in recruitment really did push us into the next gear and allowed us to really continue the project in a way that was super effective. And what are our next steps? So really the next step is to apply for our second phase of funding through the HCCF fund. And the next phase will be the implementation phase. We want to continue working with our advisory group and ensuring that we're leveraging their expertise and insights to refine and enhance the program throughout the implementation process. Conducting community consultation with community organizations is crucial in the next phase, in the next steps for us. Again, to really understand what their capacities are as organizations, what they want to achieve, what they want to accomplish by developing a smoke cessation program in their organization, and to really understand the community needs as well. We will continue gathering feedback to tailor the program to the specific community needs. And then we will get to pilot the program and adjust as needed. We're not sure how it will turn out, but only one way is to throw something against the wall and hope it sticks. And if it falls, we figure out how to make it stickier. So with that being said, that is the end of our presentation, and we'll open the floor to any questions that you might have.
So I shared some resources on tobacco and nicotine cessation in the York region for people to access. If anyone has any questions, please feel free to just post them in the chat now.
Those are some great resources that I guess we're looking forward to looking into those and connecting with you maybe offline.
So Angie asked, how does one identify a B3 organization?
That's a great question. And I know across the system, there's not necessarily a repository of, a list where we can see kind of where all these organizations exist. One thing I can note is that many of these organizations are in the community. So it's really about partnering with community members who maybe have a better sense of where some of these spaces are. I find generally, it's one of the key values that we find when we're working with a lot of Black communities is just this really understanding that there's often not a lot of representation in Black leadership in different spaces. So I think a lot of community members hold that knowledge in terms of where some of these organizations are, and finding leaders or champions in some of these spaces who can maybe help point you in the right direction of other organizations as well that are Black-led, Black-focused, and Black-serving. So I'd say that's usually a great place to start if there's any leaders or community members that are in your network who might be more familiar with some of these organizations who can help make kind of these warm connections. And from there, we find a lot of the providers tend to know each other. It's a kind of it's a large community, but it's also in many ways a small community. So from like a research standpoint, it's almost kind of like this idea of like snowball sampling, so to speak, where one connection helps lead to another. Jama, I don't know if you had anything you would like to add to that.
I was going to just echo those same points and ensure that, maybe reaching out to your own networks. You never know what kind of work is happening across your organizations. And I'm not sure which organization you're coming from, but in an organization as big as CAMH, for example, you never know what kind of work, what kind of collaborations already exist, and trying to leverage those existing relationships. And as someone mentioned, I believe as Ayaz mentioned before in the chat, it's really important to find organizations that align with the work that you want to do and align in those values and those missions that they aim to achieve. So it's not just identifying a B3 organization, but it's identifying the right B3 organization as well.
That's great. If anyone has any more questions, feel free to post. But I'll also note if anyone has any questions that come up after anything, here are Kevin and Jama's emails. Please feel free to reach out to them with any questions. So we'll just move forward. Thank you, Kevin and Jama, for an engaging and informative webinar. I just want to remind everyone that this webinar is recorded, and I will be distributing a link to it as well as a copy of the slides by tomorrow afternoon. And please feel free to share this with your colleagues as well. I'll also be sending a link to the evaluation and post-learning assessment that should be completed by next Wednesday, February 28th, if you want to receive a letter of completion for this webinar. I just noticed another question. Kim wants to know, are there any differences you noticed across different ages, for example, young adults versus older adults?
Yeah, maybe I can start and then feel free to add in where you like. I think certainly, anecdotally at the very least, but I think through some of the analysis, are really hoping to comb through some of these subtleties. But I think particularly with the younger folks, we definitely see a difference in terms of how they're accessing and how they're maybe consuming tobacco products. So in terms of like mixing with cannabis use, for example, I think was one of the themes that we came across, particularly with some of the younger folks. I mean, not to say it was exclusively to the younger folks as well, but I think very likely a higher prevalence in terms of that. Also, when you look at experiences, I know not quite in scope of what we're particularly focused on in this particular study, but experiences and uses of like vaping and other methods of consuming. I think we are seeing a little, as we kind of move towards some of the other spaces, a higher prevalence in some of those pieces as well. And I think in terms of older communities, I think there was a lot of communities that didn't really feel like I think one of the themes that we really noticed, didn't really feel they had a safe space to even start these conversations. So I think through a lot of the focus groups that we co-facilitated, there's many folks that commented just even participating in a process like this was so therapeutic. I know, it's research and you don't want to necessarily blur the lines, but just having a space to talk about, some of these racial challenges that have related to smoking, for many folks maybe not even having made the connection until an opportunity like this study presented, and really some of the older folks who have kind of been struggling with trying to make some health changes or behavioral changes to support their health, rather, noting that like projects like these would have been so important for them maybe in younger spaces to really have an opportunity to talk about it.
Yeah, Kim adds a bit more later on, asking about the differences in engagement preferences. I know that when we were talking with some of the older folks in the focus groups and interviews, they found that they engaged more because they engaged with the project simply because they were attending their own community health organization. They're attending their community organizations. They saw the posters there and they were like, okay, cool, there's a phone number. Let me just reach out, versus a lot of our other younger folks who are more mainly engaging. They engage because they saw something on Instagram and they're like, oh, cool, this is on Instagram. I feel like this resonates with me. I want to join it. But similarly for both, they really did engage because they found that they had spaces that weren't previously available to them to really talk about issues pertinent to smoking cessation. Some of the participants talked about the fact that it created a safe space for them to really engage and to share some of their experiences. And a lot of the experiences that we heard, while obviously every person goes through their own different set of challenges and experiences, there was a lot of similarities that we might have seen as well. But I found that engaging with them, participants engaged in different ways. They became a part of this project through different routes, but at the end of the day, participants just wanted somewhere safe to discuss some of these issues that they faced. And really for the individuals who participated in this project and for so many others who didn't have the opportunity based on timing or other responsibilities that they had to attend to, they just want to see something available to them and something that they feel like is representative of themselves. They see individuals who have gone through similar experiences to them leading the project or leading a program, and just ensuring that they are represented in a way that is culturally responsive and really just respectable to their experiences overall.
Thank you. Again, their emails, Kevin and Jama's emails are right here. They'll also be in the slides sent out if anyone has any other questions. Just continuing, our next Teach educational rounds on STOP program in long-term care will be on March 20th, and there will be more information on registration coming soon. And if you missed part of this presentation or want to see a previous Teach webinar, they can all be found on the Teach website as well. So for now, thank you so much for listening and participating, and thank you to our presenters as well. We hope everyone has an amazing rest of their day. Thanks.